So let us continue where we have stopped. Now the next question is about anal fistula. Anal fistula, if you take any fistula should have what? It should have two ends, right? This is, suppose, let us tell this is a fistula. So anal fistula, like any other fistula, should have a opening on both sides. So there will be an external opening and there should be a internal opening. Depending on the internal opening, we can divide the fistula into whether it is a low level fistula or whether it is a high level fistula. Okay, now coming to the types of anal fistula. Here what you are going to see, this has to be your internal anal sphincter and this has to be your external anal sphincter. So when you see this green line is passing between the internal anal sphincter and the external anal sphincter. That is the reason why I have to call it as a intersphincteric type of anal fistula. Okay, now when you see this violet line, this is going or it is traversing both the internal anal sphincter and the external anal sphincter and it is coming outside. So I have to call it as a transsphincteric anal fistula. Now there are other two types also which are not important to your exam. So intersphincteric accounts to 45% of the cases, transsphincteric accounts to 40% of the cases of the anal fistula. However, the most common type is it low or is it high? Yes, it is a low level fistula. And yes, you already know it has to be a intersphincteric fistula. This is the most common type of anal fistula. Now coming to the anal fistula, what are all the clinical features of a case of anal fistula? Whenever there is a fistula, there should be a discharge, right? So there will be perianal discharge. Perianal discharge will be there. Next, obviously there will be pain and sometimes there will be constipation also. But please remember, perianal discharge and pain are seen. Now, what are all the examination? On examination, what are all the things you can see? When I examine the area, I can see the external opening. Now, will I be able to see the internal opening also? No, I cannot see the internal opening, which is internal. On examination, I can see the external opening. So if I have done proctoscopy, then I may or I may not see internal opening. Sometimes I may see, and sometimes even on proctoscopy also I cannot find out the internal opening. There is a rule in anal fistula. It is Goodsall's rule. What is this Goodsall's rule? In a simple way, I will try to explain you. Suppose this is the anal opening or the external anal opening. I am going to divide this into anterior and the posterior halves. Anything which is above is anterior, anything below which has to be a posterior half. Suppose the external opening is in the anterior half. What happens? The tract is going to be straight and the internal opening is going to lie at the same position. Okay, I will show you here. If the external opening, let us say this is 1 o'clock position, is in the 1 o'clock position, the tract is a straight tract and the internal opening is also going to be at the around 1 o'clock position only. Suppose if I take this 11 o'clock position, the external opening is there. Then also in the 11 o'clock position, I am going to see the internal opening. By chance, if the external opening is in the posterior half, if it is in the posterior half, then the tract is not going to be straight. It will be a curved tract. So the internal opening will be in the midline posteriorly. It will be in the midline at 6 o'clock position. Suppose let us take this is 4 o'clock position, but as it is in the posterior half, the tract is going to be a curved one, and the internal opening will be in the midline posteriorly. This is what Goodsell's rule is going to tell me. Okay. Now, how to investigate a case of anal fistula? MR fistulogram is the investigation of choice. So investigation of choice has to be MR fistulogram. Now, MR fistulogram may tell me whether it is a low level fistula, or it can tell me that it is a high level fistula. Coming to a low level fistula, how to manage this case? I have two options. One thing I can do is fistulotomy, and the other thing I can do is fistulectomy. Write down. One is fistulotomy and the other thing is fistulectomy. These are the two options I have. But out of these two things, what I am going to prefer? I am going to prefer fistulotomy. I am going to prefer fistulotomy only. Okay. Next, the moment it is a high level fistula. High level fistula, what should I do? One option I have is set-on insertion. I have to insert a set-on. So what is the advantage with the set-on means? Set-on is going to, this set-on is going to drain the fistula. Whenever you insert a set-on, this set-on is going to drain the fistula. Yes, it helps in drainage. It helps in draining of the fistula. Not only that, it also helps in healing from inside to outside. Now, so under low, I have already told you, if the low level fistula, fistulotomy and fistulectomy, the preferred one is fistulotomy. Under high level fistula, now I am telling you, the first one is set-on insertion, and the second one is anorectal advancement flap. Advancement flap is the second option I have, and the third option I have is lift. What is lift? Ligation of intersphincteric fistulous tract, that is called as lift. These are the options I have in case of a high level fistula. Next, coming to a case of femoral hernia. Femoral hernia, where it is coming out through? Yes, femoral hernia comes out through femoral ring. Femoral hernia comes out through the femoral ring. Okay. Now, maximum risk of strangulation is seen in case of femoral hernia. Please remember. I will explain you what is obstruction, what is strangulation, and what is incastination in a inguinal hernia module. Right now, please remember, maximum risk of strangulation is seen in femoral hernia. Femoral hernia comes out through which ring? Femoral ring. Now, femoral hernia is mostly seen in females. Compared to males, it is much more highly seen in females. The question is, why females have a more risk of getting this femoral hernia? Because you already know they have a wider pelvis. As they have a wider pelvis, they are at risk of developing a femoral hernia. Right. And one more thing I want to clarify now itself is, if a femoral hernia is more common in, without any doubt, my answer is the same thing. Femoral hernia is more common in females. That we have already studied. But now my question is, what is the most common hernia seen in females? The answer is not femoral hernia. It has to be indirect hernia. Whether it is a male, whether it is a female, the most common hernia seen is always a indirect hernia. Okay. Now, coming to the clinical features. So you already know here any case of hernia, mostly they are going to present with swelling. So here also there will be swelling, but swelling where? In the groin region. So the patient is going to present to you with a groin swelling, right? And I have already told you there is a risk of strangulation, means sometimes there will be acute intestinal obstruction features can also be seen when they present to you with the obstruction or a strangulation. Now, now we have to examine this hernia. What is the most important landmark here? That is pubic tubercle. Why it is important, I will tell you. Pubic tubercle. Why? Because if the neck of the swelling is going to be above and medial to the pubic tubercle, then what is that hernia? It is not femoral hernia, it has to be inguinal hernia. Okay, if the neck of the swelling is below and lateral, if it is below and lateral to the pubic tubercle, then what it is? Then it has to be femoral hernia. Okay, I want you to remember this. Now coming to various approaches to treat the femoral hernia, I can incise at the level of the inguinal ligament, or I can go a high level approach, or I can go for a low level approach. The names are different in these three types. If at all I am going to do a high level, then it is called as McEvedy. If at all I am going to do at the level of inguinal, then the name is Lathyessence. If at all I am going to do a low level, then the name is Lockwood. Okay. Now coming to the next one. Now, oh, sir, you told me 3, but what is the surgery of choice? Write it down. Surgery of choice in case of femoral hernia is total extraperitoneal repair. I will tell you about total extraperitoneal repair in case of inguinal hernia only. But as of now, please remember, surgery of choice is total extraperitoneal repair more than McEvedy. And one more thing I want you to write it down. Surgery of choice in case of emergency means somewhat there is an intestinal obstruction or a strangulation is there, then the surgery of choice is always McEvedy. Okay. Now coming to the Seminoma testis. So coming to Seminoma testis, I will explain you whatever, everything is written on the board already. Just to concentrate on what I am going to tell you. Right. Okay. Suppose even before Seminoma testis, actually this is asked as a 2 marks question, but I feel like this is going to be one of the important topic only in the future also, and even some exams already asked this question, Seminoma testis. That is why somewhat I have elaborated here. Now, Seminoma testis, first we will talk about the testicular cancer per se. Whenever we take a testicular cancer, it is divided into 2 types. One is seminomatous and the other is non-seminomatous. So one is seminoma and the other is non-seminomatous. I mean, even before going to seminoma and non-seminoma, these testicular cancers are of many varieties, but 90 to 95% of the testicular cancers are of germ cell type only. That is why I have removed all those other things. I have included only germ cell tumors. Why? Because 90 to 95% of the cases of testicular cancer are due to germ cell tumors only. That is why I have excluded sex cord tumor cells like Sertoli tumor, Leydig tumor, and other tumors I have eliminated, and I have kept only 2 things from the germ cell tumors. And one branch is seminoma and the other branch is non-seminoma. Coming to non-seminomatous germ cell tumors, you have 4 important entities there. teratoma, embryonal cell cancer, yolk sac tumor, and choriocarcinoma. Okay, these are the 4 types which are there in the non-seminomatous type. Seminoma, you need not know. I mean, there won't be any types to be at your exam level. So, 50% of the cases of the testicular cancer are due to seminoma. Obviously, remaining 40% may be due to non-seminomatous. Now, seminomas are going to present in the 4th decade of life, whereas the non-seminomatous germ cell tumors are going to present in the 3rd decade of life. If you look at both the things, whether it is seminomatous or non-seminomatous, the age of presentation is in the 3rd or the 4th decade. Means testicular cancer is, when you are looking at a testicular cancer, it is not about age 60, age 70. It is all about the ages in the 3rd and the 4th decade. Okay. Now, move ahead. So, what are the risk factors for this testicular cancer? One, you already know cryptorchidism. Second thing is also you already know Klinefelter. And the third thing is the family history of a testicular cancer. These are the 3 risk factors. Now, coming here. Okay, yes. Now, let us look at some pathological aspects of the testicular tumor. Whenever you are going to do a cut section on gross, what you can see? You can see a homogeneous pinkish appearance of the tumor you can see. Now, if you have done a microscopy, what else you can see? You can see that there is a fibrous stroma you can see. You can clearly see the fibrous septa you can see. Okay. So, the cells are separated by fibrous septa. So tumor cells, you can see tumor cells which are oval, round in shape. You can see the nuclei also. You can clearly see the nuclei. So fibrous septa is the one which is forming the lobules. Lobules are going to contain the oval shaped tumor cells, within which you can clearly see the nuclei also. Right. If you carefully try to observe within the fibrous septa, I have drawn small blue color things. What are they? It is lymphocytic infiltration. Very important. Lymphocytic infiltration is seen in testicular cancer. That is seminoma. I mean, we are seeing seminoma now. Okay, this microscopic picture is also of seminoma, right? In seminoma, we can see the oval-shaped tumor cells within the lobule, and the lobules being separated by a fibrous septa, and you can see lymphocytic infiltration within the fibrous septa also. Now, moving ahead. You know, gross we have discussed, homogeneous pinkish appearance. Microscopy, if you see oval cells with clear cytoplasm and large rounded nuclei, you can see lobules will be there, which will be separated by the fibrous septa. Now, active lymphocytic infiltration is seen. Very important. If at all, if there is active lymphocytic infiltration, means the host immune response is very good, means the tumor is going to have a good prognosis. Okay. Now this seminoma is going to spread via lymphatics. It is not going to spread via hematogenous route. It is going to spread via lymphatics. So what is the lymphatic drainage of the testis? It is the para-aortic lymph nodes. That is why there may be involvement of para-aortic lymph nodes in seminoma. Seminoma spreads via lymphatics only. Now, how a testicular tumor, now forget about seminoma, we are taking a testicular tumor per se. Now, there is a testicular tumor. How it is going to present? It is going to present as a painless testicular mass, or a lump you can call painless testicular mass. The moment you see a painless testicular mass, you have two things in your mind. One thing, whether it is a fluid collection or whether it is a solid one. The moment you see transillumination positive, the moment you see fluctuation being positive, the moment you have done an ultrasound, it is also telling you that it is cystic in consistency, then probably you are dealing with a case of hydrocele. If at all transillumination is negative, fluctuation is also negative, and on ultrasound also confirms you that it is a solid in nature, then you are mostly in line of solid testicular mass, which is mostly due to a tumor. Moving ahead, the moment you see a solid testicular lump, what is the management? High inguinal orchidectomy. I want you to remember, but before orchidectomy, you are measuring the levels of the tumor markers like alpha fetoprotein, HCG, LDH, all those things you are going to measure. But your mainstay of treatment is what? High inguinal orchidectomy. But before orchidectomy, get the levels of the tumor markers done. If the tumor markers are negative, what to do? High inguinal orchidectomy. If the tumor markers are positive, what to do? High inguinal orchidectomy. Irrespective of what you are going to get, you have to get a high inguinal orchidectomy done, right? Sir, then why I am going to use the tumor markers? Tumor markers help me in diagnosing. Okay, so let me tell you example of yolk sac tumor. Yolk sac tumor will have alpha fetoprotein. Choriocarcinoma will have HCG. Like that, there will be tumor markers will help in the diagnosis. That is why we are doing. Why? Because after surgery, measuring them is of no use. Before you have to measure, and after that, to assess the response to treatment, you can use the tumor markers as a reference. Okay, the moment you are giving treatment, whether the treatment is working or not, you can assess by the levels of these tumor markers. Okay, that is why before doing high inguinal orchidectomy, always get the tumor marker levels done. Whether they are positive, whether they are negative, it doesn't matter. You have to go for a high inguinal orchidectomy done. Right. Now, CT chest, CT abdomen and CT pelvis should be done. So to stage the tumor, you have to do all these things. You can get this done after doing inguinal orchidectomy also. There is no problem. Now, coming to, and one more thing is there is no role of biopsy also. Biopsy also you should not do, okay? Directly straight away you have to go for high inguinal orchidectomy. Now, I am dividing it into 3 stages. This is not the actual staging. For the sake of simplicity, I am explaining you in 3 stages. Stage 1, stage 2, stage 3. Stage 1 means there is no metastasis. Stage 2 means there is lymph node metastasis. Stage 3 means there is distant metastasis or there is lymph node metastasis only, but with elevated tumor markers is also there. So stage 1, stage 2, stage 3. Stage 1 no metastasis. Stage 2 lymph node metastasis. Stage 3 distant metastasis or lymph node metastasis with elevated tumor markers. That is stage 3. Now, how to distant mets? You can, one point I want to mention here. There is lung metastasis. Cannonball metastasis of the lung are seen in testicular cancer. Where else we are going to see them? We are also seeing them in renal cell cancer. Very important. Now, I have already told you stage 1, stage 2 and stage 3. First one we are going to see stage 1, which is a non-metastatic cancer. Treatment is different whether it is a seminoma or whether it is a non-seminoma. Okay. If I take a seminoma, what is the treatment? I can give a chemotherapy or I can give a radiotherapy. Chemotherapy is using carboplatin. Radiotherapy, where what is the area I have to give? Para-aortic field is the area I have to give radiation. Now coming to the non-seminomatous germ cell tumors, how to treat them? Using chemotherapy. Which chemotherapy regime? BEP regime. B means bleomycin, E means etoposide, P means cisplatin. BEP. Okay, obviously testicular cancer you have to treat using platinum based chemo. In case of seminoma, I can use a chemotherapy which is based on cisplatin, or I can use a radiotherapy giving to the para-aortic field. Whereas in case of a non-seminomatous germ cell tumor, I have to give chemotherapy using BEP regime. B means bleomycin, E means etoposide and P means cisplatin. Now, even I have to do a retroperitoneal lymph node dissection in case of non-seminomatous. Okay. This is how I treat a stage 1. Now coming to the stage 2 treatment. Nothing much of a difference. In stage 2, I am going to give a BEP regime. One point I want to mention straight away is most of the seminomas are going to present to us in the stage 1 only. Even 75 to 80% of them are going to present in the stage 1 itself. Whereas coming to the non-seminomatous, 40 to 50%, around 50% of them are going to present in the stage 1, and some of them may present in the advanced stages. Okay, stage 2, you have to give chemo BEP, same BEP, bleomycin, etoposide, cisplatin. Right. I have already told you this point. There is excellent response to chemotherapy in case of these testicular cancers. If you take seminoma, not only chemotherapy, radiotherapy is also giving excellent responses. Next topic. Okay. Just wait a second. Okay. Coming to congenital hypertrophic pyloric stenosis. Congenital means what? It has to be a pediatric problem. Now, hypertrophic pyloric stenosis, right? First point I want to mention here is it is seen in firstborn male child. Firstborn male child. It is seen in firstborn male child. So, what is the age at presentation? I want you to remember this. They are not, even I'm using the term congenital, but they are not presenting immediately after birth. They are going to present in the 3rd week or the 4th week after birth. Write it down. Child age between the 3rd week to the 4th week they are going to present. And one more point I want to emphasize here itself is maternal use of erythromycin during pregnancy may lead to congenital hypertrophic pyloric stenosis in the baby. Okay, maternal use of erythromycin. Now please tell me, pyloric stenosis is already there. So where is bile present actually? Bile is going to enter into the duodenum. Now, if at all there is a vomiting in this case, will it be a bilious vomiting or a non-bilious vomiting? It has to be a non-bilious vomiting. Why? Because duodenum is somewhere below the stomach. There is already obstruction between the stomach to the duodenum. That is, pyloric stenosis is already there. So can it be a bilious vomiting? The answer is no. It has to be a non-bilious vomiting. Non-bilious vomiting is the presentation. Initially it is a non-projectile vomiting. Non-projectile vomiting initially. Later on it may be projectile also. Now there is already obstruction in the pylorus of the stomach. Now there is stomach. There is continuation here. So I am going to see what visible peristalsis I can see. Okay, visible peristalsis I can see, which is from left to right. Visible peristalsis from where? Left to right direction, very important. And I am going to see a mass. On examination, I am going to see a olive shaped mass. Olive shaped mass. In which region I am going to see the mass? Obviously in the epigastric region. In the epigastric region, right? So the best time to see this mass is after vomiting, or I can see this during feeding also. Next thing, very important, what is the electrolyte abnormality which is seen here? Now due to vomiting, what happens? HCl is something which is going outside. HCl which has to be present in the stomach is going to, due to vomiting, it is going to go outside. Even potassium also. Now what is the entity we are going to see here? Hypochloremic hypokalemic metabolic alkalosis. Okay, I want you to remember this: hypokalemic metabolic alkalosis with paradoxical aciduria, in long standing cases. In long standing cases I can see paradoxical aciduria. So hypokalemic metabolic alkalosis, right? The same thing I am going to see in case of gastric outlet obstruction also. I am going to tell you the same thing. Pyloric stenosis is there or gastric outlet obstruction is there. Both of them are almost a similar entity, but this is a completely congenital issue which is seen in a pediatric, that too 3rd week to 4th week of life. But gastric outlet obstruction, maybe due to a malignancy or some other cause, is usually seen in the elderly. But electrolyte abnormality, why? Because same problem is going to occur in both. This is also outlet obstruction. Pyloric stenosis also something like a outlet obstruction, and both of them has to present with a hypochloremic metabolic alkalosis with paradoxical aciduria in the long standing cases. Mechanism why these electrolyte abnormalities are occurring is not necessary to read and write in the exam. Just remember that. Now I have to do correction of the electrolytes. Correction of the electrolytes has to be done. So what is the first electrolyte I am going to correct? Yes, I have to correct potassium. First I have to correct potassium, and then I have to correct the bicarb levels. So next, what is the best fluid which can be used in this case? Half normal saline plus potassium chloride plus dextrose. This is the best fluid to use in this case, or I can use a ringer lactate also. Now okay, now tell me, what is the investigation of choice in case of this congenital hypertrophic pyloric stenosis? Yes, it is ultrasound. So there is some criteria in ultrasound to tell. Okay, I will show you here. So there is hypertrophic pyloric stenosis, right? Here the pylorus region is going to be narrowed. So what happens here is the length of the canal, if it is more than 16 mm, or the thickness, the wall thickness is more than 4 mm, then it has to be a case of congenital hypertrophic pyloric stenosis. Please write it down. Investigation of choice is ultrasound. More than 16 mm canal length, more than 4 mm wall thickness. Always I have to consider as congenital hypertrophic pyloric stenosis. Next, on X-ray, so investigation of choice is basically ultrasound only, there is no doubt in that. But I want to tell you what are the X-ray findings and what are the barium meal findings. There are some named signs which you have to remember. Now on X-ray you can see something called as single bubble sign. Single bubble sign on X-ray. Single bubble sign on X-ray is a feature of congenital hypertrophic pyloric stenosis. Double bubble sign on X-ray is a feature of duodenal atresia. Triple bubble sign on X-ray is a feature of jejunal atresia. Please remember these three things. Coming to barium meal, on barium meal you can see a mushroom sign, or you can call it as a string sign. You can call it as a string sign. Why I will tell you. So you can see something like this over. So this will be your stomach area. Okay. So due to that narrow passage, when you do a barium meal, you can see this narrow line. So this line is very narrow. This narrow line appearance, I am going to call it as a string sign. After that, this is something looking like a mushroom. That is why I am calling it as a mushroom sign on barium meal. Now, how to treat this case? How to treat this case? What is this hypertrophic, right? Now, that is why I have to do laparoscopic Ramstead, name of the operation, Ramstead pyloromyotomy. I have to give a incision to the muscle. I am not removing the muscle. I am giving incision to the muscle. Sir, how to give? So this is, I have clearly mentioned here. I have to give a incision to the muscle. Now I have to give only till a particular depth. I should not go and perforate that. I have to give only till the muscle layer. I should not go to the mucosal level. So if at all during surgery mucosa has got breached by somehow, then I should not start oral feeds till 48 to 72 hours. If mucosa has not got breached, then within 4 to 6 hours I can start the oral feeds. Okay, this is all about congenital hypertrophic pyloric stenosis. Firstborn male child, erythromycin in the mother, presentation 3rd to 4th week, olive shaped mass in the epigastrium, non-bilious vomiting, non-projectile vomiting initially, left to right peristalsis will be there. Investigation of choice being an ultrasound, more than 16 mm canal length, more than 4 mm thickness, wall thickness. On X-ray single bubble, on barium meal mushroom sign or a string sign. Treatment being laparoscopic Ramstead pyloromyotomy. Then mucosa got breached 48 to 72 hours. Not got breached within 4 to 6 hours. You can start the oral feeds. This is all you should know about congenital hypertrophic pyloric stenosis. Now coming to a case of Flial chest. Flial chest, if you remember, first thing is Flial chest is also called as stove in the chest. Flial chest is also called as a stove in the chest. So first write the definition of a Flial chest and then I will explain you. To fracture in 2 or more consecutive ribs. Fracture in 2 or more consecutive ribs at more than one point in one line. So what is the meaning of this? Quickly we will try to understand what it is going to say. Fracture in 2 or more ribs. Yes, this rib has got fracture, this rib also has got fracture. Fracture in 2 or more ribs. Now 2 or more consecutive ribs. Yes, they are consecutive ribs at more than one point in one line. Here also in this rib there is fracture here, there is fracture here. In this rib also there is fracture here, there is fracture here. Means there should be a fracture in 2 or more consecutive ribs, and within one rib there should be a multiple fractures. More than one fracture should be there in a single rib also. That is why this has to be our Flial chest. Okay, this red one which I have highlighted has to be the Flial segment. Okay, now what is the problem with the Flial segment? Flial segment is going to show me paradoxical respiration. Very important. What do you mean by the paradoxical respiration? Means normally what should happen? The ribs has to expand during inspiration and they come closer during inspiration, during expiration. Now what happens to the Flial segment is when the chest is expanding during inspiration, the Flial chest is coming inwards. Okay, when the chest is coming inwards during expiration, this Flial segment is going outwards. That is why this is called as paradoxical respiration, which is seen in Flial chest. Now what is the investigation of choice? You already know, rib fracture, chest x-ray is the investigation of choice. How to manage a case of a Flial chest? Not only Flial chest, if I take a fracture rib also, most important thing is pain. I have to control the pain. Pain control is most important in a rib fracture. So management, I have to provide, the first step I have to do is I have to provide oxygen and I have to do a pain control measure. Now, by chance, if the SpO2 is less than 85 even on oxygen, the SpO2 is less than 85% or PaO2 is less than 60 mm of Hg, means I have to assume that there is a respiratory failure going on. Now, I cannot, now if the SpO2 is less than 85 and even PaO2 is less than 60 now, I cannot continue the patient on oxygen only. I have to move to the next step, intermittent positive pressure ventilation. Intermittent positive pressure ventilation. This is the treatment of choice in case of flial chest. One thing I want to mention, please, we are studying flial chest in surgery only. I too know, that is why we are discussing here. But the treatment of flial chest is not a surgery. Operative fixation is not the treatment of choice. Treatment of choice is always intermittent positive pressure ventilation. Last resort I have is operative fixation. Last resort I have is operative fixation of the ribs. Operative fixation of the ribs. Okay. Now tell me, what is the most common cause of death in case of a flial chest? I have already told you there is a flial segment. So one thing is flial segment is undergoing paradoxical respiration. That's one thing. But the other thing is the part of the lung which is beneath the flial segment is going to undergo pulmonary contusion. So most common cause of death, if you ask me, in case of a flial chest, the answer is pulmonary contusion is the most common cause of death. So flial chest I have already explained you. Fracture will be there in 2 or more consecutive ribs at more than one place in one rib. And clinically, you already know that the patient is going to come with you with the pain. And also the patient may have some respiratory symptoms also. Now, what is the investigation of choice? I have to get a X-ray done. Now, how to